Hi, my name is Abir and I'm a final year medical student. In this video, I'll be teaching you all about bowel obstruction. You will learn about the causes of bowel obstruction, history and examination findings, and what investigations you would do. You will also learn about how to manage bowel obstruction and the complications that can occur from it. But first, what is bowel obstruction? Bowel obstruction occurs when food, fluids, and gases are unable to pass through the gastrointestinal tract. This is due to a blockage in the intestine. There are two types of bowel obstruction, small bowel and large bowel obstruction. There are many causes of bowel obstruction, and these can be split into extrinsic, intrinsic, and intraluminal causes. Extrinsic causes include adhesions, which occur after surgery, hernias, which occur when the intestine pushes through a weakness in the abdominal wall, and a volvulus, and this is when the bowel twists on itself. Intrinsic causes include inflammatory bowel disease, cancer, specifically colorectal cancer, and diverticulitis, which is an outpouching of the bowel. Intraluminal causes include gallstones and a foreign body. The three main causes of bowel obstruction to remember are adhesions, which usually form in the small bowel, hernias, which also usually form in the small bowel, and malignancy, which are more common in the large bowel. If any of these occur in the small or large bowel, it means that food can't pass through the gastrointestinal tract, and therefore it will get stuck in the intestines, and this can cause a variety of symptoms. If a patient has bowel obstruction, the main symptom they will complain of is abdominal pain. Small bowel obstruction usually presents with pain that is more in the center of the abdomen, and it's colicky in nature. This means that it comes on in waves. In contrast, the pain in large bowel obstruction is lower down in the abdomen and it's more constant. Patients usually have a distended abdomen, and vomiting and constipation are key symptoms. To help you identify the type of bowel obstruction, you can look at the timing of these. Small bowel obstruction has early vomiting and constipation is the late sign, whereas large bowel obstruction presents with early constipation and vomiting may develop later. Patients may not have passed wind or stools for the few days before presenting to you in the hospital. If a patient presents with abdominal pain, you need to perform an abdominal examination. When inspecting the patient's abdomen, look for any masses, and this might suggest cancer or a hernia. Check for previous surgery scars, which might suggest adhesions as the cause of the bowel obstruction, and also look for abdominal distension. When palpating the abdomen, feel in the 9 abdominal quadrants and look at the patient's face as you're doing so to check if they're in any pain. Feel for any tenderness, any guarding which might suggest peritonitis, and also feel for any masses. After percussing the abdomen, you'll need to auscultate and listen for any bowel sounds. In bowel obstruction, these will be absent or tinkling. And don't forget to perform a rectal examination for completion. Once you've examined your patient, the investigations you should do are a set of bloods, which are a full blood count, urea and electrolytes, a CRP, and a group and save. A venous blood gas should also be done. And remember, if your patient has been vomiting, a metabolic alkalosis will be seen. You may also see a raised lactate, and this is due to ischemia, which is a worrying sign as it suggests that the obstructed bowel is not receiving a blood supply. An abdominal X-ray and an erect chest X-ray should also be done. This might show a perforation, which is a complication of bowel obstruction. Your gold standard investigation for bowel obstruction is a contrast CT abdomen. Recognizing small and large bowel obstruction on an abdominal X-ray is a common exam question. On the left, you can see this image showing small bowel obstruction, and this is because the distended bowel loops are in the center of the film. And you can also see something called the valvulae conniventes, which are these thin lines that go across the whole bowel segment, giving it a coiled spring appearance. In contrast, in large bowel obstruction, the distended loops are on the peripheries of the film, and you can also see something called haustra. These are lines that don't pass across the whole bowel segment. Bowel obstruction is an emergency, and you need to make sure that you're taking an ABCDE approach to stabilize the patient. Your patient needs to be nil by mouth, as they should not be eating or drinking due to the obstruction. and you should insert an NG tube to remove fluid and gas and help relieve the pain and pressure. You should start them on IV fluids and give appropriate analgesia, and these steps are the first line management for bowel obstruction. If the patient is still in pain or the obstruction is still persistent, then you can refer the patient for surgery. The mainstay treatment for bowel obstruction can be remembered by the term drip and suck, where drip is the IV fluids and suck is the NG tube. There are many complications that can occur from bowel obstruction. These include dehydration and hypovolemic shock, strangulation, which can occur when there's a segment of bowel that's trapped, and this can cause ischemia due to a lack of blood flow to that area. Sepsis can also occur, and perforation can happen, and this can be seen on an erect chest X-ray as a bubble of gas under the diaphragm. Now that we've gone through those topics, here's a short quiz you can use to test yourself. Pause the video so you can read the question and give an answer. Give yourself about 30 seconds for each one, and then press play when you're ready to see the correct answers for both of these questions. The most likely diagnosis for this patient is large bowel obstruction, and this is because the patient has abdominal pain, constipation, and absent bowel sounds. Remember, constipation is an early sign in large bowel obstruction, and vomiting is a late sign in large bowel obstruction. The likely cause of this is malignancy and colon cancer, and this is because there is a mass in the left lower quadrant of the abdomen. Pause the video again to answer the second set of questions. Give yourself about 30 seconds and make sure you press play once you're ready to see the correct answer. The investigations you would do for this patient include a set of bloods, so a full blood count, urea and electrolytes, CRP and a group and save. You can either do a VBG or an ABG, get an erect chest X-ray, an abdominal X-ray and a CT abdomen. To manage the patient, you should take an ATE approach, keeping the patient nil by mouth, giving IV fluids, inserting an NG tube, giving the patient analgesia and considering surgery. Here's a quick summary of everything we've spoken about in this video. Remember, the three main causes of bowel obstruction are adhesions, hernias, and malignancy. The key symptoms are vomiting, constipation, abdominal distension, and not passing any wind. Main management includes taking an ATE approach, keeping the patient nil by mouth, inserting an NG tube, and giving the patient IV fluids. That completes this video on bowel obstruction. If you found it useful, please leave a comment down below and let me know what other topics you'd like me to go over. Finally, don't forget to give this video a like and subscribe to my channel.